All right, everybody. Thank you all so much for joining us today for our discussion in regards to COVID-19 and the Delta variant. We are joined by Dr. Nestor Sosa, who is the Division Chief of Infectious Diseases here at UNMH. We've had him prior in doing these trainings for us the past, I would say, 6 months. And so we're so grateful for him to continue doing these trainings for us to educate us on the ongoing changes and what's happening with the Delta variant. He will be doing a short presentation and we'll have some time at the end. So if you have any questions that have been lingering for you with the ongoing changes with the Delta or the COVID-19, this is the perfect time for you to ask those questions. You can place them in the chat, or you can also use the Q&A section where I'll keep an eye on that. We are also live on Facebook for this session. So those of you joining us on Facebook, please also put that in the chat on Facebook and I'll keep an eye out on that. As we really want to make this as informative as possible. And so with that being said, thank you so much, Dr. Sosa, for being here with us today.
Thank you very much, Teresa, and really thank you for inviting me. For me, it's really an honor, and I love these sessions because it allows me to sort of be in contact with the community, and at the same time, I really thank you for all the work you are doing here in New Mexico. I came here 2 years ago, and I feel really like at home in Albuquerque and in New Mexico. So for me, it's really a pleasure to be here. So let me share my screen. Let me see if I can put it in large screen. Perfect. Can you see the full screen? Okay, perfect. Okay, so I'm going to actually try to talk about a little bit of the update of the COVID-19 epidemic with some emphasis on the Delta variant. And I'll try to explain some of these graphs I present to the scientists and colleagues here at the university, but I will try to explain us in a very understandable way. But obviously, if you have any questions, we'll have plenty of time for question and answer at the end. Or if you have any particular aspect that I haven't really talked about, I'm more than glad to try to answer the question if I can, because there are many things that we obviously do not know with this new virus. So let me minimize the image of the photos and I'll go. Okay, so the first thing I always like to sort of take a perspective of this situation or any situation. And in the case of the pandemics, it's important to try to understand and compare this current pandemic, this COVID-19 pandemic with other pandemics that we have had in the past. And as far as we know, at least there have been 3 or 4 pandemics of respiratory viruses in the 20th and 21st century. And one way to measure the impact is actually to measure what is called the excess mortality. So, governments and health systems usually monitor how many people die every year. It's a pretty reliable number because, people get death certificates and it's reported, etc. So we know even in countries where there's no good diagnostics or tests for any disease because they don't have the resources, when somebody dies, it's recorded, it's actually counted. So one way is to see how many more people have died during the pandemic. It's a way to really measure objectively the impact. And let me show you, this is a study that a group have done, a group of investigators, and it was published in the scientific literature. But just to give you an idea, there have been at least 5 pandemics since 1918 to the present. The first 4 were all secondary to influenza. So in 1918, the so-called Spanish flu, 1957, 68, the 2009, which was the H1N1. Many of us remember that new virus and that pandemic a few years ago. And obviously in latter part of 2019, 2020, and 2021, the COVID-19. These scientists, what they did, they adjusted the population of the world to the current 2020 population. And you can see the number of total death associated with the pandemic. So in 1918 was the highest, and it was 75 million deaths in the world. This is in the whole planet. And you can see the other pandemics, 3 million in 1957, 268, less than 500,000 2009. And then this is our current estimate, or the current estimate for the COVID-19, around 6 million. So it's obviously the most impactful pandemic, with the exception, obviously, of the 1918. So that's important to understand, because when people try to disregard COVID-19, it's the same as the flu, it's just a common cold, etc. These have really made an impact on a lot of people, not only causing death in 6 million human beings, but also producing some chronic diseases like what it's called the long COVID or post-acute sequela of COVID-19. So I just wanted to give you that sort of 35,000 feet perspective of the pandemic and the impact on mortality compared to other historic pandemics that have occurred. The other interesting or important point of view is to see how the pandemic has behaved in the world. Sometimes we are centered in our city or our community, and we don't look at the whole planet. So this is according to the World Health Organization. This is actually a graph of the cases of COVID throughout the pandemic, and you can see that there have been at least 3 waves. One wave was at the end of 2020. This was the big or large wave that occurred basically in the United States and many other areas of the world at the end of 2020. Then we had another one in the spring, really very close together with the one in December. And now we live in the 3rd wave. And this 3rd wave, it's largely driven by Delta, by this new variant. And I'm going to explain shortly what variants are. Because the virus is changing continuously, there are still people susceptible, and this is our 3rd wave, which, by the way, the tendency is to go down. So it's starting to decrease, definitely decreasing in many countries in the world, starting to decrease in some areas of the United States, but still we have areas where there are many cases that are occurring. Obviously, you can see there were peaks and valleys. The valleys were actually associated with, because this was before vaccines, these valleys in the curve were associated with social distancing and public health measures, because vaccines were really introduced in some countries around February, March. Probably the US was one of the earliest, Israel and the UK, but many places in the world have not really started any significant, the vaccination to any significant degree. Okay, so let's talk about variants, and we're going to concentrate obviously on the Delta variant. And the first question, what is a variant, or why do variants occur? So this is an illustration of the virus. The virus has genetic material like any other living organism, and there's a debate about the fact if our virus is alive or not. But in any case, for our discussion, they have either RNA or DNA, and this RNA and DNA, when the virus is replicating, there are alterations, and are illustrated here by these red dots. So there are minimal changes every time the virus replicates. There are some changes in their offspring. Some of these changes are irrelevant; they don't change the behavior of the virus or the consequences of the virus. But some other times, really, a new strain is created or appears, and that new strain or variant, we use the word variant for these modest changes, then the new variant can be associated with either more transmissibility or more severe disease. And that what really distinguishes or makes a variant of concern or a variant of interest by the WHO, when it's actually showing different behaviors in human population due to the fact that it's spreading more rapidly than the previous or the parental strain, or it's causing more severe disease. A larger proportion of people end up in the hospital or with complications. So that's basically the reason why variants occur. Obviously, the more transmission, if there are a lot of people infected, there's a lot of replication or virus reproduction, and the more virus reproduction, the more variants appear in the community. So that's why it's so important to try either with the vaccination or with non-pharmacological interventions like the social distancing, the masking, washing the hands, etc., improving ventilation to decrease the appearance of this variant, because these variants, as I said, can be difficult to control because the immune system do not recognize them completely, or they could be associated with more severe disease. What do we know about this Delta variant, which was actually described at the end of 2020 or discovered at the end of 2020 in India and rapidly disseminated throughout the world? The first thing is that the Delta variant is associated with a higher amount of virus in respiratory secretion, 1,000 times higher viral load or amount of virus in the nose or in the pharynx, so in the upper respiratory tract. And that probably explains what is much more transmissible, because if a person is infected, it will shed more viruses into the environment. It will release more virus when they're talking, when they're coughing, when they sneeze or sing. So any activity, even with breathing, they're going to be putting more viruses into the environment, and then other susceptible individuals can get infected. There's also evidence from different studies, especially in Scotland, in the UK, in India, that Delta is also associated with a higher degree, maybe a 2 to 4 times higher odds of hospitalization and admission into intensive care. So it's not only more transmissible in the way that more people get infected, but it's also associated with a higher proportion of hospitalization than the previous or older variants like Alpha and some other variants that circulated in the 2020 waves. And actually, one way to see this transmissibility, the scientists have been able to calculate how many people on average a person with COVID infects. So with the original Wuhan virus, one infected person, here illustrated in sort of a light blue color, can infect 2 people. And in fact, in average, infected between 2.4 and 2.6 individuals. This is obviously an average. There are people who infect 10, others who infect none, but sort of an average or a mean of 2.4 to 2.6. If we jump to Delta, the estimates is that one infected person can transmit the disease to an average of 5 to 8 individuals. So really a much more transmissible disease. These levels of transmissibility are only seen with like childhood diseases like mumps and measles. We don't really see that many other viruses with this high transmissibility. So Delta is right up there, slightly less than mumps and measles, probably similar to chickenpox. So it's very, very transmissible, especially if you compare with the original Wuhan virus, or even with the Alpha that circulated in the winter of 2021, which was infected 4 to 5 people. So this is almost double 8 people for every person infected. Again, this is an average. I've seen cases of large outbreaks where one person can infect 20, and other cases where one person infects no person. I mean, it basically doesn't transmit to other individuals. So this is sort of an average, and it's very, very variable in the individual person. The other interesting fact is that actually the Delta has become rapidly the dominant strain, and this is the proportion of Delta variant in Health Region 6, which includes New Mexico, Oklahoma, Louisiana, Arkansas, and Texas. And you can see the different dates here: May, June, July, and as late as the middle of May, most of the variants circulating was this one, B117, which is the Alpha. So you can see the color, the light orange color was the Alpha. The Alpha was king in that region 6 in the United States. And in a couple of weeks, just a matter of a few weeks, Delta became the dominant and essentially eliminated completely the other variants. And you can see that almost 100% of the samples are Delta in this whole region of the United States. If we look just at New Mexico, the same picture, and these are the data from the genome sequencing that is done here by Daryl Dinwiddie and Daryl Doman at the university. And you can see there was a mix of different colors, meaning different variants circulating in February, March, April, May. But then what happened in July and August? Boom! The totality of the virus sequence in New Mexico are now belonging to the Delta. So it's basically taking over the transmission in our region without almost any exception. So that also speaks in favor of the high transmissibility, because it basically more efficiently transmitted than other variants. So it becomes a dominant really rapidly. Okay, let's talk now about vaccines and how Delta affects vaccines. First of all, we know from clinical trials that at least 3 vaccines are used in the United States. This is the Pfizer, BioNTech, that now is called Comirnaty, the mRNA, which is the Moderna vaccine that is now called Spike vaccine. And we have the Johnson & Johnson, the J&J vaccine. So these are the 3 vaccines. When they were studied, they have pretty high efficacy. They were able to demonstrate almost perfect protection against disease, 95 and 94% for the 2 doses of the mRNA vaccine, the Pfizer and Moderna, and around 66 to 70% of the J&J, which was only 1 dose. So it's less number of doses, a single shot, but a pretty decent protection. What we have seen with the Delta variant, it's a decrease in this efficacy of preventing disease, and you can see how this number, the prevention of symptomatic disease, has really dropped from the 95, 94 that was demonstrated in the original studies to lower numbers. For instance, in England, it was calculated around 88, in Canada, 87, Scotland, 79, and Israel, which has the more sort of somber data, the efficacy went down in one publication to 64. So there's no doubt that the Delta variant is impacting the frequency of symptomatic disease. So people who are fully vaccinated definitely can get the infection, but we will see that some things are not that bad. For instance, the hospitalizations and severe disease, the protection doesn't seem to wane that much. So at least data from England and earlier in Israel, 96 and 88% protection. So although we can get infected, even if fully vaccinated, the risk of hospitalization is much less, and we'll see some data, some additional data in favor of that. So the vaccine, the Delta variant, seems to affect the capacity of the vaccine to protect to such a high level, 95, 94%, nevertheless protects you against hospitalization and death. And this is another way to put it. Eric Topol, which is the director of the Scripps Institute in San Francisco, he's basically following the literature, and these are all different sources of information and publications, and these are the vaccine effectiveness. And you can see, for instance, in England, what I mentioned, 88%, but if you look at some of the most recent data, are actually talking about 40 to 70% effectiveness against disease. A study in the Mayo Clinic, a study done in Qatar in the Middle East, was also around 55 for Pfizer, 84 for Moderna. So definitely there's evidence of some waning of protection, and that's the main reason why people are talking about boosters. And you have heard the White House saying that there were going to be boosters available for the public in September, etc., because we are seeing some degree of waning of protection, especially among elderly individuals, people who are over 65, and especially patients or subjects who were vaccinated in January, February, so that they have been already vaccinated for 8 or 9 months. In those populations, there's some evidence of waning, but again, as I said, the waning of protection is against disease or against asymptomatic disease, but not really that much against hospitalization, ICU admission, and death. The other concern that you have seen in the newspapers or in the news outlets, the concern about children, and actually the CDC analyzed the data of the trends in COVID-19 cases in children and adolescents, basically 0 to 17 years in the United States from August 2020 to 21. And the good news is that, number one, although there's obviously the large peak in December that I mentioned before, this is the cases in kids in different ages. So there was definitely a significant number of cases. These are cases per 100 people. So the peak was around 50 per 100 people in December. With the Delta, there's definitely another peak, but you can see that the peak is not as high as it was in December. So yes, it is true that Delta is affecting children. more than if you compare to what was going on in February and April, much less number of cases in children, but still lower than the highest peak in December. So that's one piece of good news. And the other piece of good news, this is the same data presented in a different fashion, but they also included the percentage of kids who actually made it into the ICU. And you can see the black line illustrates that percentage. And you can see that throughout the pandemic, there have been sort of a 20% frequency of kids going into the ICU. So yeah, there's been a sort of an uptick with the Delta, but it have never surpassed the severity of the other variant. So although kids are affected, the good news is that they're not more severely affected with the Delta if we compare with Alpha that was around here and some of the original Wuhan strains that were circulating here at the end of 2020. Okay. And then the other battle that we have seen is the vaccinated versus unvaccinated. And we have heard the president and many other experts say this is the epidemic of an unvaccinated versus vaccinated. So I'm going to show some data of what happened when you're vaccinated and what happened when you're unvaccinated, according to the data, to the evidence that we have. First of all, if you have been infected with the virus, there was a nice publication. If you had COVID and you're not vaccinated, you have pretty good and sustainable antibodies. So obviously, we always talk about the protection conferred by the vaccines, but having the disease also give you some protection. Although I have to mention this, once you have COVID, if you get the vaccination, your levels of antibody go really high. Actually, a lot of immunologists, a lot of experts said that if you had the infection and then you get vaccinated, you have the most powerful, the strongest immunity, which is called the hybrid immunity, because your body has seen the virus, the real thing, and you have seen the vaccine, which is like the purified version of the spike protein. So you have the best protection. But definitely, I mean, being infected gives you some degree of protection that may wane over time. But in this study, they actually measure antibodies out to 10 months after infection. And you can see the dots in the graph illustrate the levels of antibody. You can see that they remain relatively horizontal. There's not a significant decrease in the antibodies with natural infection. So that's important to mention. The people who have had COVID have some degree of protection, which can be, again, as I said, improve a lot with vaccination. So even if you had COVID, and that's what they're recommending, that you get at least one, ideally 2 doses to have the best protection, which is the hybrid protection. But let's see some data of unvaccinated people. And I like to illustrate this outbreak was reported in the Morbidity and Mortality Weekly Report of the CDC. In this case, and this is an illustration, this is a teacher in her class. These are the students in the class. And this teacher was unvaccinated. Unfortunately, she was unvaccinated. And although they were all wearing masks most of the time, the kids were wearing masks, the teacher actually removed the mask to be able to read out loud to the student. What happened? 12 out of 20, and she got COVID, and then almost half of the class, or exactly half of the class, 12 out of 24 got infected with COVID in that class. And you can see in red are those affected, and in gray, those who did not become infected. And you can see, like in the front rows, the first 2 rows of the classroom, 80% of the kids got infected. So this really illustrates the risk of being not vaccinated, because you can obviously spread it to people around you. And the second thing, if you remove the mask, the risk obviously increase, even if the kids have a mask on. So that's why it's so important for everybody, not just the student, but actually the teacher. And you can apply this to any other situation, healthcare providers and their patient, to wear a mask and also to be vaccinated. So that's the first sort of a sad story, but a real story. And even those on the back of the room, 28% got infected. So 28 out of the students on the last 3 rows of the classroom got infected. So that's important. And they were using open windows and some other mitigation, but despite that, the teacher unfortunately infected those kids. There's another study very recently published just a few days ago on September 10 by the CDC, in which they actually compare vaccinated with unvaccinated individuals in 13 US jurisdictions. So this was during the United States and during the Delta. And even with the Delta, people who are vaccinated versus, or people who are not vaccinated have a 5-time higher risk of infection, 10 times, more than 10 times higher risk of hospitalization, and 10 times higher risk of death if you're unvaccinated compared to the vaccinated. Yeah, the vaccines are not 100%. There's infections, there are breakthrough infections that have been well documented, but numerically, the risk is almost 1 log or 1 order of magnitude greater if you're unvaccinated, your risk of hospitalization and death. And we have seen many reports of like 90, 95, 99% of people in hospitals right now are unvaccinated. And yes, you can see one person who's fully vaccinated and develop the disease and may even have a complicated course and die, but that's the exception and not the rule. The risk is much higher if you have no immunity, zero protection from the infection or because you haven't been vaccinated. And this is graphically the same thing. These are the graph of the epidemic, the so-called epidemic of the unvaccinated in black and vaccinated. And you can see that there are 2 different shapes. I mean, and this is July with the Delta peak. You can see, yeah, the vaccinated people, even fully vaccinated, has some increase, some uptick in the number of cases, but the curve of the unvaccinated is way up here, 150 times, 150 per 100,000 cases. If you see hospitalization, it's even more dramatic. The curve of hospitalization in vaccinated, yeah, there's a small trend here upwards, but you can see what happened in between June and July with the Delta variant in the United States, how this unvaccinated group actually went up really significantly. And the deaths, the same thing. We have an increase in the death in the unvaccinated, barely no increase in the vaccinated. Not zero, but almost a negligible amount of death in the fully vaccinated population. So it's very evident, any way you look at this, that there's a difference between being vaccinated and not being vaccinated regarding cases, hospitalization, and death. And the final topic that I want to mention are the boosters. So are boosters really necessary? And actually today, the FDA is discussing the need for boosters. So we have to stay tuned to the news this afternoon when they come up with a more detailed recommendation, or in the next few weeks, because actually I don't think they're going to reach a conclusion. But yeah, because of the waning of protection against infection, people are considering the need for a booster or a third dose to improve immunity. And I just want to close the discussion reminding everybody about the safety, because I have talked about efficacy, effectiveness, so how helpful the vaccine is, but it's important to mention the mRNA vaccines are extremely safe, but there are some allergic reactions. There are people who develop severe allergic reaction. It's very infrequent, but we have seen that it's a treatable condition. And that's the reason why when people are vaccinated, they have to wait 15 or 20 minutes after vaccination to make sure they don't have an allergy to them, to the injection. There have been a lot of press about a transient myocarditis, which is an inflammation of the heart. This is usually reversible. It's seen in younger males more than females and younger patients. It's an inflammation of the heart muscle, which tends to be part of the reactogenicity or the fever and the symptoms that you feel with the second dose, and then it goes away. But it's something that it needs to be considered and treated if it occurs. And finally, is with the Johnson & Johnson vaccine, which belongs to this adenovirus vaccine. There's a rare, very rare complication of thrombosis with thrombocytopenia that is called VEAT, and also the Guillain-Barré syndrome. But these are really infrequent, and I actually gathered from the literature the frequency. For instance, the allergic reaction, which is called in medicine anaphylaxis, the severe allergic reaction occurs 11 per 1 million people vaccinated. So 11 per 1 million. Myocarditis, 12 per 1 million. The thrombosis, 7 per 1 million, and the Guillain-Barré, 8 per 1 million. So you have to vaccinate a lot of people to actually see a few of these rare, extremely rare cases. And some of these things are totally treatable, like the myocarditis and the anaphylaxis are treatable conditions, and so is the Guillain-Barré. The thrombosis is a little bit more severe, but it's treatable also with something called IVIG. So we can recognize it on time and treat it if they occur. And as you can see, it's very infrequent. So in summary, we have living through the second deadliest pandemic in the last 100 years. So with the exception of the 1918 pandemic, this has been the most important pandemic in 100 years. We still see cases. You saw the peaks and valleys of the curve in the world. We're still seeing new cases and variants in other countries. I think we need to vaccinate the rest of the world to try to put a break on this pandemic, or at least make it like an endemic disease that doesn't affect the health system. Definitely the Delta variant that we are having, it's highly contagious. It's associated with more severe disease. And it's also affecting to some degree the vaccine effectiveness. So that's the reason why we're talking about boosters now, 9 months after we started vaccination here in the US. But remember, vaccines are highly effective. I have shown the so-called vaccinated versus unvaccinated war. And even with the Delta, you get protection from hospitalization, severe disease, and death. Okay, thank you very much. I'm going to stop sharing and go into this question and answer session. Thank you very much.
Thank you so much, Dr. Sosa. This is a meeting-based training, so you are more than welcome to unmute yourself if you have any questions. We do have one question that was asked earlier about the RO for measles and mumps. Is that an average in an unvaccinated population, or are there ROs for vaccinated populations as well?
Yeah, excellent question. Yes, this is an average in unvaccinated. So that is, they are not calculated for measles and mumps. It's from the historical times before vaccination. If a person with measles, let's say a student, gets into a classroom where nobody's vaccinated, nobody has had measles, they can spread the disease to that high number of people. But yeah, so those are historic. Obviously, if you're fully vaccinated with measles, your risk is almost zero. Especially if you've been recently vaccinated, you're almost completely protected against measles with vaccination. But yes, that's a great question. Those numbers are sort of the natural ability of measles or mumps to be transmitted in unvaccinated individuals. And to be honest, there are not changes also, although we take it as a very reliable number. It's different. If you live in rural New Mexico and there's nobody around you and you get measles, you're probably not going to spread it to anybody. But if you live in New York City, and you ride the metro in New York City every day and you have measles, you're going to infect 20 people in that metro if they're not vaccinated. So R0 has to be adjusted to the reality. I mean, they incorporate the sort of a numbers to guide us, but in reality, it's different for different population, different living conditions, etc. It's really not applicable to all situations automatically.
Thank you so much for answering that question, Dr. Sosa. I do have Angie Estrellas with her hand raised.
Yes, thank you, Teresa. Dr. Sosa, do you have a recommendation for weekly testing? We're a domestic violence shelter, so weekly testing regardless of vaccination status for the staff. That's one thing I've been wondering about doing as part of our safety protocols. Do you think that's too much? Is it a good idea for the shelter side of operations? Thank you.
Yeah, there are a lot of experts who actually advocate for frequent testing, even in vaccinated individuals, because of the waning of the protection against infection. Even if all the staff and all the residents in a facility are vaccinated, the testing will detect those, especially those with mild infections or infection that almost look like regular cold, with just like congestion and sneezing. So yeah, so there is that recommendation, and I think it's an added value, an added prevention. Fighting this virus, the best thing is to put as many layers or obstacles to the virus. So the vaccination is one obstacle, social distancing and masking when possible, when feasible, it's another layer of protection, and definitely testing. And testing every week, it's exactly what the CDC recommends. I do not recommend less frequent testing, like every couple of weeks or every 3 weeks, because the incubation period of the virus is so short, it's 4 days, that if you have a person infected and you don't test in a week, when you test in 2 weeks, everybody will be already infected or exposed. So it's not very useful. And there are places like we here at the University of New Mexico, the sports program tests 3 times a week the athletes, because an infection in a team is catastrophic, because they are together, they train together, they're like practicing and actually sharing respiratory secretions all the time when they're exercising. So we do testing 2 to 3 times a week to be able to detect as soon as possible. So in normal conditions, and the CDC advocates testing every week, that will detect infection even in vaccinated and definitely in unvaccinated individuals, and will help rapidly isolate a person. And also it's important to highlight the turnaround time. If you do testing, but the testing result gets back in 3 or 4 days, it's probably not very useful. It's better to use rapid testing or a rapid turnaround time, maybe less than 24 hours, because of the transmission. The Delta is transmitted 2 days before symptoms begin. So if you imagine, if you test a person who's asymptomatic and you have to wait 2 to 3 days to get the results, they will, and to make the decision to put them on isolation or distance that person from the rest of the workers, it will be too late. When the result comes back in 3 days, he's already infected 3 or 4 more that you have to do, and then the same thing with the rest. So it's the faster the turnaround time, the better. And definitely it's another layer, another help. And they're actually very experts who are actually advocating for more testing. That we haven't been that aggressive with testing in the United States. We had that issue at the beginning. Maybe somebody remembers the problem with there was no diagnostic testing, and it was so hard to get. We never got really on top of that and got used to testing. But there's a lot of places in Europe and in other places where they test very frequently everybody. I mean, especially in work or companies, factories, schools, etc.
Just to follow up then, so on our non-shelter side, we have staff in an administrative building, which you also advocate for weekly testing of those staff if they're coming in. It's a smaller group and clients aren't coming in right now.
Yeah, I don't think there's a way to over-test. Really, it depends on your budget, how inconvenient, how difficult it is. I'm not obviously familiar with your system, with your shelters, etc. To give you sort of a categorical, but I can tell you there's no way to over-test if it's very disruptive, if it's affordable to the funds that you have, you will definitely pick up some cases. Obviously, also the strategy has to be related to what's happening in the community. If we have a very active transmission in the community, obviously testing will be more, you will get more money, more bug for your monies, more benefits of testing. If the curve is really down and there's no transmission in the community, then you're probably not going to get as many meaningful positive tests, and you may even get false positive and get more confused. But if you have, an outgoing, an active transmission in the community, then that's definitely a useful, especially people share the same space and they are exposed to each other, is definitely a way. But it's always a decision of cost, inconvenience, etc. But I think there's no way to over-test. There's no risk to testing. Physical risk. I mean, the swab has really it's completely harmless. So that it's something that may be helpful, and it's never too much.
We were going to use the vault system, which is a saliva test. Do you know anything about the rate of false positives? Or
no, specifically, I cannot speak specifically, but I know the saliva tests have been validated in many settings. So it's another useful test. I mean, tests always have limitations. No matter what test you do, you will have false negative, you will have false positive. But if you do it frequently, if you are on top of what's happening in your community, it's usually a useful thing to do, and will, as I said, add another layer of protection to your coworkers or your public or yeah.
Thank you so much for your questions, Angie. Thank you, Dr. Sosa.
Thank you.
The next one, my screen moved a little bit, so I apologize. The next one that I see with their hand raised is going to be Dolores Lewis.
Hi, good morning. I just wanted to know that can you get the Delta variant if you've already had like the other COVID virus?
Yeah, that's a great question. The answer is yes. There have been cases of what we call reinfection, people who actually had COVID in, let's say, March, April, June, July of last year, and they have developed the Delta variant, infection with the Delta variant. Yes, it is possible. Obviously, if you had COVID, you have more protection than if you have not have COVID before. You know, with natural infection, you get exposed, develop some antibodies. So probably your overall risk, if you had COVID last year or at the beginning of this year, it's better than a person who had never had contact with the virus. That's a fact. We know because we have measured the antibodies. We have seen the immune system actually active against the virus. But unfortunately, it's not 100%. So there are people who, despite having COVID before, can develop what we call a reinfection or a second infection. And that's what the CDC and all of the experts recommend, that even if you had COVID, to get a shot, because there are people who say, oh, I had COVID, I don't need the shot, I don't need the vaccine. There's a lot of evidence, not one study, probably 10 or 12 studies in different countries, which show how well protected you are if you had COVID and then get a shot. And then you have like a huge booster, because the immune system have seen both. I've seen the virus and now have seen the spike protein and it develops very robust antibodies and immune defenses against the virus when you have the and actually we call it hybrid immunity, like the hybrid cars, because you have both immunity to the virus itself and immunity to the vaccine, and that seems to be the best protection. But unfortunately, if you had COVID, you still have the risk of developing second infection. Actually, if you want a number, there have been studies done on healthcare workers, and it's around 80% protection. So the protection of infection gives you like an 80%. It's not as good as an mRNA vaccine, which presumably is 94, 95. But it's right up there. 80% it's good. It's some protection. So you have some degree of protection, but it's not perfect. So you can still get it. You can still transmit it. Even if you had it once, you can have it twice.
Can you still get the Delta variant if you're vaccinated?
Yes, that's a good question. Let me just reiterate. Yes, there have been, and we call the breakthrough infection. People who were vaccinated can have an infection, but the infections, number one, are usually milder, shorter in duration, less likely to transmit, less likely to become severe and go to the hospital. But yes, you can have the Delta variant, unfortunately, despite being vaccinated. But again, it's risk. And use the analogy of the seatbelt or the helmet. If you're riding your bike or a motorcycle without the helmet and you have an accident, your chances of surviving are much less. If you hit your head against the ground at 40 miles or 50 miles, you're probably not going to survive that impact. If you have the helmet, you may not survive. You may have some other injury that kills you, but the helmet gives you a protection. The same happens with the vaccine. It's not perfect, but it's much better than having no protection against the Delta. So yeah, unfortunately, it is true you can get infection with Delta if you're vaccinated, but numerically, it's less of a risk of getting it, of transmitting it to other people, and also if you get it, to go to the hospital and die. It's not zero, but it's much less than not having the vaccine before. But great question.
Thank you for answering that question. The next one that I have up is going to be Andres Garcia.
Thank you, Dr. Sosa. I work in a high traffic area. Has there been any updates to any studies about transmission through surface area?
Yeah, great question. No, there hasn't been any updates. If anything, I think the feeling is that objects, inanimate objects or surfaces, are less of a problem than we thought at the beginning of the pandemic. We all remember, the hype buying Clorox or one of those things. And I myself put my shoes when I got from the hospital. I put my shoes like in a special container in my door at the house before entering my house, etc. Now we know that probably over 90% of the transmission is through respiratory secretions. When you talk, when you sneeze, when you sing, when you do, even when you breathe, you are expelling into the air these microscopic little drops that actually can be inhaled by a person in front of you. Even at longer distance, there have been outbreaks in restaurants in when the infected person was in this corner of the restaurant, and the other one that got infected from that index case, it's on the other side, because there's some like very light particles that we expel when we breathe that are weightless. They basically float in the air and they can stay in the room. So yeah, so although there is transmission associated with surfaces, with objects like, you know, doorknobs and things, we think now that it's much less than at the beginning. It's not zero. You cannot like disregard, no, don't wash your hands, don't clean surfaces. That's not what I'm saying, but probably most of the transmission occurs some other way, especially to respiratory. So you still have to, if you have an infected person in an office, you have to disinfect, you know, the keyboard, the computer, the area. You have to clean the floor because the virus drops into the area, and in case you touch that area and then you bring your finger to your nose, or scratch your eye, you can be infected that way. It's probably not that frequent, but it happens, and that's what we also insist in all these other layers: hand washing, surface cleaning, using the alcohol gel, because there's some 10% of transmission that occurs that way, but most of the transmission is through respiratory route, and that's the insistence with the mask and with the social distancing, because you're trying to put some barriers for the virus to cross, for the infection to be successful. But it's a good question, Andres.
Thank you.
I do have a follow-up question. We'll ask it just because it pertains to this question. You stated that, you know, the transmission is by sneezing, by coughing, talking, singing, all of that. We do have a question that states, how long do those particles last in an enclosed area, either on a plane, in an office, in a car, or just a small area that...
Right. Yeah, that's a great question. I don't think the scientists have a magic number. It depends on many factors, and I'm going to explain the factors. Actually, number one is the ventilation of the room, just to mention the first one. If you have, a very good air conditioning, if you have HEPA filters in the air system, if you have open windows and open doors, the duration of those particles in the air are much less. Okay, if you're in an enclosed environment, very small room, no air circulation, they can last for hours. I think I've seen experiments in which they can last in the air for 12 hours. Imagine, so almost half a day in the perfect condition. This is humidity, darkness, etc. There's some things that, thank God, they don't happen all the time. I mean, there's always some type of air circulation, dispersion. So it can last for a long time. So I have a friend, a colleague, who actually, when he sees a patient with COVID, he opens the windows on the door for a few minutes, try to see the next patient in another room before going back into the original room. I mean, that's probably a lot of complication, but because he's an infectious disease and he sees COVID patient every day, and he also tells the house staff, if they enter that room, to wear an N95, because that person was there breathing for 10, 15, 20 minutes, the time that the medical visit lasted. And probably in the air of that room, there's going to be some virus. The opposite end, it's an outdoor, sunshine, wind blowing event. If you go to the Domingo Vaca Park, at noon, it's probably less risk if you compare that with my small office here, which is completely closed and with air conditioning. So it's sort of there's a lot of variability how long the infectious virus, but definitely lasts for minutes to hours in an enclosed environment with ideal condition. And that's why it's so important to improve ventilation, to try not to crowd in places like bars and restaurants, which are, a lot of people in a small confined, and they're usually shouting and singing and, very happy with their margaritas. So they're sharing their opinions actively, and they're also sharing their virus. If one is infected, everybody else is going to be breathing that happiness with the virus. So it's important to point out. I suppose if you're by yourself in an open space in a park, the risk is basically zero, because the chances of inhaling a particle there with the virus is probably negligible.
Perfect. Thank you so much for answering that question. The next hand, I will get to the ones that are in the chat. We do have April Armijo with her hand raised.
Hello, Dr. Sosa. Thank you for this presentation. It's a lot of excellent information, and thanks for answering the question about.
I think you muted.
Yeah, April, you muted yourself. Yeah,
Oh, hi,
ahead.
sorry.
that's okay.
Okay, thank you for the presentation. I was saying that, this is excellent information and you're really putting it all together in a good way that we all can understand. And thanks for answering my question about the R0 for mumps and measles, because I've always wondered that. But I have two more questions and I'll try to keep them short. I know early on the FDA gave the EUA for rapid antigen tests, but only in symptomatic patients. And I know the PCR is still the gold standard, but at this point, like with the sports program, are they using antigen tests for asymptomatic patients or people too? And is that okay or encouraged? And the second question is reinfection rates. I know early on the DOH was, they're compiling information and they had some numbers that seemed alarming, but the ratio of reinfections to the population, like you needed more data and they didn't have it at the time. Do you know about rates for reinfection and what you currently see in practice?
Yeah.
And how often does that happen?
Okay, good question. Yeah, first of all, about the antigen test. Definitely antigen tests are less sensitive than PCR tests. That's number one. So if you can afford and you can have a rapid turnaround time with a PCR would be better. Although that said, antigen tests are sensitive enough to be very helpful, especially if you do them frequently, and that's more than once a week or at least once a week. It's very useful and definitely have demonstrated the ability to detect early outbreaks and try to abort outbreaks in small communities, in like sport facilities, etc. And there are also a lot of evidence, or not a lot, but there's some evidence that especially for symptomatic individuals, of the FDA recommendation, if you're tracking people with symptoms and use an antigen, is very useful because in that case, it will be positive most of the time. So the sensitivity in people with symptomatic individual is very, very high. So it's sort of a trade-off. If you can get away with doing PCRs and having a rapid response, PCR is best, is more specific and more sensitive. But a lot of people and a lot of systems do not have that luxury, and they have to rely on antigen. Antigens are good enough for 80 to 90% sensitivity. So you're going to miss some cases, but if you do it frequently, that case that you missed the first day because the viral load was very low, you're going to pick up the following testing cycle. So you're probably still going to derive some benefits from doing frequent antigen tests. And so frequency in this case overrides or compensates for the lack of sensitivity compared to the PCR. The second question, the reinfections, I don't have a magic number. What I can say are what they have calculated based on healthcare workers and other people who have had 2 infections. The estimate of protection from infection, as I said, is 80%. So you can look at it the other way. There's a 20% risk of reinfection. If you were infected, you have a 20% protection, lack of protection or residual risk of having reinfection. I think it depends on several factors. Number one, the severity of infection. If you had a very mild infection, almost asymptomatic infection, probably your protection is less than if you had a real, struggle with COVID in 2020 or the early 2021. Your immune system will probably be better off, and you have less chances of having a second infection with Delta or whatever variant comes down the line. So that's one, severity of disease. Also the time, if your infection was in March of 2020, you probably have some waning of the protection, and it's been a year and a half since that original infection, and you probably have more risk compared to somebody who had the infection in June that have less than 4 months. So that person still have a pretty robust immune system. So those factors affect the reinfection rate. And to be honest, it's a little bit hard to calculate the reinfection rates for several reasons. First, because a lot of people do not document the first infection. There's in many places where people they felt they COVID, but there was no documentation of that first COVID. And then also the people who have like a persistent positive PCR, and it can confuse a second infection with just the first infection lasting longer. So those are practical difficulties studying the frequency of reinfection. But I would say in general, infection confers protection, probably around 80%. It wanes over time. So the longer the time has spent since the original infection, the less protected you are. And also depends on your first infection. If your first infection was really mild, your protection is probably not 80%, but maybe 60 or 50%. If you had a symptomatic severe infection, you're more protected down the road.
Thank you
so
Dr.
much.
I just wanted to clarify, what does PCR stand for?
It stands for polymerase chain reaction. And I explain briefly what they do in the lab. They take the sample, and they actually, there's a way to try to detect if there's RNA present and how much is present by doing what we call a polymerase chain reaction. There's an enzyme that actually builds the RNA in the test tube if there's RNA present. So if there's like the original virus, you can actually make more using this polymerase, which is the name of the enzyme. So it's just the name of the reaction, the polymerase chain reaction, and it's done at high temperatures because it was discovered in actually in a bacteria that lives in vents, in hydrothermic vents. So it's very interesting, the history of the PCR, but it's just to detect the presence of genetic material. And it's using it's not only using virology, it's using, if you guys have seen CSI, the police thing, you can detect human DNA in a crime scene by using PCR. So it's used for many, it has many uses, this PCR reaction, but it basically detects RNA or DNA of living organisms in a sample, in a crime scene, in a tissue, even in a prehistoric mammoth. You can find the DNA of the mammoth and try to study that DNA in an archaeological finding or paleontological study. So it's very interesting, but it's just to detect RNA and DNA.
Thank you so much for clarifying. I do see 2 more hands raised, but we do have a couple questions in the chat. So Rose is asking, for people who smoke, are there any specific side effects anticipated from getting COVID-19 vaccine?
Yeah, that's a good question. There's actually sort of a debate in the literature. There have been studies in which smoking have been associated with more severe lung disease. There were some studies that they didn't see that association. So it's either neutral or a deleterious or negative effect. Obviously, if the person have chronic lung disease, if they have, they have cigarette smoking and they already have bronchitis or emphysema, secondary to the smoking or even lung cancer, obviously they do much worse with COVID, because COVID is a lung infection on top of a lung disease is like much more difficult. But maybe, somebody who doesn't have any lung disease may not fare that bad if they're smokers, especially early in their life. If they're young and they're smokers, there's probably not that much of a difference. But definitely, if you have cigarette-induced lung disease, is definitely a risk factor for more severe COVID. Absolutely.
Thank you. Soledad Aguirre?
Yes, Dr. Sosa. Is it safe to test on a weekly basis? I mean, for the body, is it?
Yeah.
Okay.
Good question. First of all, most of the rapid tests and the tests that are available commercially, they really go into just the opening of the nose. So it's really not, and it's with a plastic or a Q-tip type of thing. It does no harm. I mean, the worst case scenario, if you do it very hard, you can have a little bit of bleed, but it won't be worse than poking your nose like kids do all the time. It's not there's really no. With the previous test, with the nasopharyngeal that's done by nurses or by doctors, it's a little bit deeper. And there have been very rare complications, nose bleeds and other complications, but you have to really go deep to do damage. I mean, if you just go to the entrance of the nose with a Q-tip and do, a quick, movement in there, it's probably completely harmless if you do every week. There's really no evidence of harm. And as I said, humoristically, but it's almost like, poking your nose, that's the risk of of doing this with a sterile Q-tip is probably no risk at all. The risks are really not related to physical harm, but to misinterpreting the test. If you get a test and it's negative, and then you go to a bar and you get COVID the following day, then the test gave you a false sense of security. So we're harmed by the sense of like, oh, I didn't have COVID, so I'm going to go party. That's a risk of the test. Or the other way around, you have a false positive. You have a test that is positive. You were not really infected. You're going to spend 10 days at home, quarantine or whatever, with a false positive test. That's the other risk of the test. Of doing tests that are not perfect, but that's part of fighting the pandemic. That not everything can be perfect 100%. Those are the real risk of testing. False positive, false negative, and also the sense of oh, I didn't get COVID, so I'm going to go to this bar, and then you get COVID the following day after the test because the test is not able to protect you from COVID, and it doesn't tell the future neither. So it's just that moment. It cannot predict the future with a test.
Thank you so much.
All right, so we're now heading over to the rest of the questions in the chat. One of them is, do the booster shots address the Delta variant?
Yeah, that's a great question. And it's actually scientifically debated right now. There are, at least that I have seen, 3 or 4 studies of boosters already. And the protection conferred by the booster seems to address the Delta variant. I mean, the number of antibodies that you get from the vaccine seems to be protected against the Delta variant. And there's data from Israel, which is like brand new data, in which they already started vaccinating 65 and older. And you can see that those vaccinated, the incidence of Delta have really sink dramatically, have gone down dramatically with the booster, as opposed to people who had not received the booster. They still keep getting Delta. Those who receive the booster are going down in their frequency. So yes, the answer, the booster, and despite the booster being from the old virus, it was made with the old virus, with the original virus, is giving protection to the Delta variant. And we hope that to other variants that are coming in the next few weeks or months, because of the sheer number of antibodies that you produce after you get this third dose or booster shot. And that's what the scientists who are pro boosters are arguing. Like, if you get this booster, you're not going to get, or your chances of getting a breakthrough infection are much less. And so in that way, even if you don't get a severe disease, you're protecting the people around you. If you work with susceptible hosts, like I do, with sick individuals or people who have like different underlying conditions, I am protecting them by getting the booster myself, because even if I don't get a disease, they may get a severe disease from me. So if I don't get infected, they don't get infected, they don't have a severe disease neither. So that's the rationale behind some of the pro-boosters scientists.
Thank you. We have a couple more questions. How concerned should an individual who had COVID, the Pfizer vaccination, and now is having food allergies, should that individual have an EpiPen available?
Right. First of all, regarding the allergies, there is not a clear association with any specific allergy and the allergies to the vaccine. The only association is with the vaccine itself or its component. So if you're allergic to bee stings, to food, to peanuts, to shellfish, or any type of allergy, by itself, that doesn't predict that you're going to be allergic to the Pfizer or the Moderna vaccine. In general, people who are very allergic, and that's have been seen in the vaccination surveillance studies, if you are allergic to something, anything, you're more likely to have a reaction. But there's no clear relationship. If I'm allergic to shellfish, I'm allergic to Pfizer. If I'm allergic to bee stings, I'm allergic to Pfizer. There's not such an association. And in general, a lot of people who are allergic get the vaccine and nothing really happens. The great majority, nothing happens to them. So yeah, I don't think there's any specific provision except for the usual. When you get your vaccine, don't run home right away. Stay near the vaccination site just in case they need to give you like a Benadryl or epinephrine or something. If you develop itching or some type of immediate allergic reaction, it can be treated right there and then.
Thank you so much for answering that question. The last question I think is very relevant at this point because some of us are parents. So if a child is exposed at school and now has to quarantine for 10 days, are all his members and all his family members are exposed, do they have to also get tested?
Yeah, it's really complicated, to be honest. Even for me, who I read the CDC website like once a week just to see what they come up. It's a bit complicated, but if you're fully vaccinated and you are exposed, and I'm going to talk in general, exposed to a child or to a person, number one, you have some degree of protection. What you have to do if you've been exposed, and it's a close contact, you need to isolate, but you can sort of get out of isolation if you have a negative test after 5 days. So you wait the 5 days of incubation period, you do a test like an antigen test or rapid test or even a PCR. And if that PCR test comes back negative, you can be taken off isolation because you were exposed, but you were not infected. If you do not test, you have to isolate for 10 days or at least monitor your symptoms for 10 days. And definitely there's an extra recommendation of wearing a mask. If you're an essential worker, you have to go back. You have to wear a mask for at least 14 days after you've been exposed, just for common sense, to put another layer of protection on the subject. But I strongly recommend people to review the CDC guideline because it's nuanced and there's a lot of details there. If you're vaccinated, if you're unvaccinated, if you're symptomatic, if you're asymptomatic. So there's a lot of different situations that you need to pay attention to. But definitely it's a situation that we see frequently, and it's, you have to apply common sense and also follow the rules of the CDC to try to decrease infection. But there is a way at least to shorten the isolation by testing negative. And even if you're the quarantine, and if you're in isolation and you test negative after 7 days, you can also get out of quarantine, which is get out of isolation. I keep confusing quarantine with isolation, which are different things. So quarantine is for people who have been exposed, and isolation is for people who are infected. That's the difference.
Thank you for clarifying that. There's a couple questions have popped up. So somebody has been looking at some data about hives because of the COVID vaccine. So it's been about 3 months. Do you recommend to take steroids or wait 6 months to see how long that will last, or should they get the booster vaccine or not?
These are hives associated with the vaccine?
I'm assuming yes.
Okay. Yeah, in that case, I would recommend for him to consult with the physician, with their primary care, because it depends on what type of reaction they had, if it was an immediate reaction or a delayed reaction. So there's a lot of details there. There have been a couple of studies on people who have severe reactions and they got the second dose and nothing happened. But I would definitely, I don't like to give a recommendation in that case, because I think it has to be consulted with your physician so he can gauge the severity of the reaction, the immediacy of the reaction. In general, we don't use steroids because steroids by itself can blunt the advantage of the vaccine. So that's what I said. This is a decision you need to make with your primary care provider. It's hard for me to say, okay, have hives, with the vaccine, what to do next. If the case is really complicated, they may even get an allergist or an immunologist to actually be consulted before you get the second dose or the booster or the third dose. In this case, we were already down to the third dose. So yes, but that will be something that I have to individualize and see what to do.
Perfect. Thank you so much for clarifying that. The next question is, how soon will vaccines be available for 12 years and younger?
Yeah, that's a great question. Last week, the Pfizer people actually said that they had the dossier, the information ready to be submitted to the FDA. I have heard from FDA representative in the media saying that probably by the end of October, beginning of November, because if they present the data now at the end of September, they usually take a month to read through it, reanalyze, check it. So, base case scenario, beginning of November for 11, from like 6 to 11. much more time for less than 6 years old. But it could take longer. I mean, if they find something and they need to go back to Pfizer and say, give me more information about this, it's another couple of weeks of information going back and forth between the company and the FDA. So I wouldn't really be that optimistic that it's going to be the best case scenario. But according to the prediction, it's going to be somewhere in November, maybe the beginning of November, that we'll have the EUA for 6 to 11 years. I think we have to actually wait. I think one country already approved it in 6 to 11, but we have to wait and see how long the FDA. But I think it's going to be at the end of the year. We're going to have that, and a little bit longer for the little kids.
Perfect. Thank you so much. One of the last questions that we have on the chat is, if your partner and you are both vaccinated, but both are positive and in isolation, can you reinfect each other? And also, what is the chance of relapse back into symptoms past recovery? Okay,
let me take the first one and then you repeat the second one. Okay, yeah, that's a good question. Nobody have really answered that. I think it's unlikely if you have the same variant. Let's say both are vaccinated, both get one get Delta, the other one gets Delta. It's going to be hard to reinfect each other with the same variant, especially in a short period of time, because you're protected by the vaccine and now by the natural infection. So it's very, very unlikely. If on the other hand, one person, both are vaccinated, but one person gets infected, they can infect the partner. So if there have been infections even from vaccinated people in house. So a vaccinated person can infect another vaccinated, definitely can infect another unvaccinated individual even easier, but it can also infect another vaccinated. I saw an outbreak in Singapore, which they actually map out who was vaccinated, who was not, and there were instances of transmission between vaccinated individuals. So they can infect each other. It's less likely, but it's possible, unfortunately, especially if they were vaccinated in January or February, 6 or 9 months ago. What was the second question about?
Yes, of course. The second question was also, what is the chance of relapse back into symptoms after you recover? Like, I guess the chances of having the symptoms again after recovering.
Yeah, that's a good question. And I'm going to talk about long COVID because really, I mean, once you recover, it's very unlikely for the symptoms to come back when you recover. What happens frequently, probably 20, maybe 30% of people who have symptomatic COVID do not recover completely. That's the plain truth. They develop this so-called long COVID in which they still experience symptoms, either respiratory, like cough, shortness of breath when they exercise, mental fog or confusion. They're not able to read a book in the afternoon because they fall asleep. They're not able to do Sudoku puzzles because they're not as sharp as before, and those type of things. And there are people who have other symptoms like loss of sense of smell for longer period of time. So there's a whole array of manifestations of this so-called long COVID that can occur after the acute infection. So you have the fever, the cough, you were in the hospital, they gave you oxygen, you go home, and then you don't completely go back to your normal self for a month. And that's called the long COVID. At the beginning, we didn't know what it was, and now we know it's well established. And there are different types of long COVID. There are people who have like respiratory symptoms, or they have cardiac symptoms, or they have mental fog, or they have different manifestations of this long COVID. Is something real, and researchers are actually actively seeking ways to help people with these long symptoms because we don't understand what's going on. We don't know if it's like the virus stays in the body longer, or is the immune system is hyperactive and it's not allowing them to feel back to normal. There are people who recover, but even kids, young kids develop long COVID. I have heard or read about kids that were football stars in their high school, and after COVID, they're not able to run 100 yards. They're really crippled. They can go to school, but they don't have the same physical ability than before because of the COVID, and they're slowly recovering, but they're definitely not as active or as healthy as they were before COVID. And that's the so-called long COVID, or now they try to call it post-acute COVID syndrome, which is sort of another fancy name for long COVID.
All right, perfect. Well, I hope that all of your questions were addressed. This is why the reason why we had this training. There was a lot of interest in past trainings, and we really wanted to offer it again, not only for our programs, but for our community members, so they can also get their questions answered by watching this. We are sharing this on Facebook, as mentioned. This will also be uploaded to our YouTube channel if you want to check back in with us and let us know your feedback as well. Again, Dr. Sosa, we just really appreciate you at the coalition. Thank you so much for always making time for us. And having these trainings and these sessions. It has been really fantastic for our programs to get answers for our survivors and for our advocates as well, right? Like COVID-19 and Delta variant has been a really chaotic time and ongoing changes, and it's just really affected us entirely. And so we just really thank you for taking time, and I hope everybody has a fantastic day. And let me know if you all have any questions and or concerns after this training. I will put my email in the chat if you have any concerns. And again, thank you so much, Dr. Sosa. We really appreciate your time. Oh, you're muted.
Yeah, no, thank you very much for inviting me. And I just want to close with just a word of optimism. I'm sure we're going to overcome this pandemic, and we will feel proud of all the effort and all the work that we put in to help our people during this pandemic, during these difficult times. We'll look back and say, okay, we did it the best we could with the information that we had. We were so sketchy, and with all the problems that we have experienced of misinformation and everything. So thank you again for all you do in the community, and I'm available whenever you need me. Thank you very much. I'll be here in my office.
Thank you so much. All right, everybody, have a fantastic day. Have a good weekend. Take care.